want to get to B as fast as possible, which is breathing. Now, adults go to C, right? But for neonates, we go to B, right? So we want to commence ventilation. So for adults, you go circulation first. For neonates, you go breathing, which is ventilation, right? Now, the ventilation you check, there is a ventilation you do when the heart rate is above 60. So you cannot do neonatal resuscitation alone. It's not a one-man show. So you need a team, and you prepare for the neonatal resuscitation, and everybody knows what to do. Somebody keeps time. Now, are you going to put a stethoscope on the chest, on the precordium of this child and start counting for 1 minute? No. The concept of golden minute, this child must breathe within 1 minute. Or this child must cry in less than a minute. So the ambobagging, which is positive pressure ventilation, it is if you do it well and the heart rate remains below 60, that is when you start chest compression. Unlike the adult that drops, not responsive, you go straight to compress. This one you position first, you ventilate. You only commence the positive pressure ventilation when you are sure that you've done positive pressure ventilation, the heart rate is less than 60. That's when you go into chest compression. And that is the C. Then the D, drugs, adrenaline, we'll see how we dilute it. In very simple terms, just get, let's say, 10 ml syringe. We draw into 10 ml syringe. Based on the weight of the baby. That's D. Then you go to endotracheal intubation, right? Now, the presentation has finished. Thank you. Okay, so let's start. Okay, so the name my father gave me is Igoche, but everybody calls me Peter. And if I'm standing with him and you say Peter, he's the one that will answer. Thank you. Please, so. How do I? Our people, let me know which one do I press. Which one? Okay. Oh, the lower one. All right, so these are objectives, right? I know that basically we'll rush through this, but for this year, we want to look at peculiarities about neonatal resuscitation in preterm babies, right? It's a special subclass. Okay, so I've been talking. So this question, let's know. Let our bag come up very quickly so we'll know. A 32-week neonate is delivered by emergency cesarean section. The baby is apneic with a heart rate of 80 beats per minute after drying and stimulation. What is the next best step? Immediate chest compression. True or false? Are you sure? What if it's a macrosomic baby? A baby is a baby. So positive pressure ventilation. Okay, let's jump that. Vigorous shaking or slapping the back of the baby. Those in support say aye. The nays have it. Right, so observe for spontaneous, just watchful waiting. Okay, so the answer is what? So all of you put your hands inside the bag that is moving around immediately. All right, so the next question is the concept of golden minute. A term baby is delivered and placed under the radiant warmer. The baby is floppy and the baby is not breathing. What should be achieved within the first golden minute? A, administration of adrenaline. B, chest compression. C, initial steps, assessment, and if needed, effective ventilation. So you see, lecture has finished, right? Okay. So which of these is the best indicator of, so we are moving from general mathematics to further maths now, right? So step up. Which of these is the best indicator of effective ventilation? A, crying. B, improved heart rate. C, pink lips. D, limb movement. Good. I like the mosaic of answers. So if you are man enough, no, sorry, I have somebody who will say I'm gender biased. If you are woman enough, right, stick out your hand and then let's see which option, A, B, C, D.
Okay, let's
Okay, no problem. That's why you are here for the presentation. If you know everything I know, then you come and stand. All right. Okay, so we start. So assistant to begin ventilation at birth. So 1 out of every 10 newborn babies will require ventilation, right? But out of this, just a smaller fraction, so 1 out of every 100 will require extensive ventilation. Let me preempt one question you will ask me. That when am I going to stop resuscitating? You have that question in your mind, right? Keep it. Because 1 out of every 100 will need extensive. What I said, A, B, C. I'm sure if you ask that question, it's because your mind stopped at C. There's endotracheal intubation, right? And then you are going to connect the child to a ventilator. So that's how far you will go. I guess I've answered that question. So this is a number of indications for ventilation, for resuscitation, which our obstetrician has talked about. So when we want to prepare, when Dr. Taiwo calls me, when he calls me from my sleep at night to come and join him in theater, right? The questions I ask as soon as I'm there, what is the expected gestational age, right? Because it matters a lot if I'm going for a post-date baby, if I'm going for a term baby, if I'm going for a preterm baby, right? Is a liquor clear? I'm in theater, and that is what I am watching. By the way, jokes apart, let me expose the answer. When I enter theater, I used to say, the pediatrician, the baby is in charge, so put off AC. And they're usually not happy, right? But you can't change it. So the atmosphere has to be warm, right? Not the AC kind of a thing. So number of babies we expect. If you have more than one baby, get another competent assistant. Don't do heroism, right? Now, these are the personnel we need, and then basic skills and the checklist. We make progress. Now, equipment that you must check. Do not leave this program and say, I have been trained, and so you will improvise. These are basics. You need this. 1, you need warmth. You need the radiant warmer to be pre-warmed ahead of the baby coming out. You don't move the baby from the warm intrauterine life through the pre-cold theater space, and you don't have a radiant warmer that is pre-warm. You clear the airway. You get a bulb syringe or a suction. Now, the suction machine, the pressure should be checked, right? Usually, it should be between 80 and 100 millimeters of mercury. It is preset, so that you do not suction soft tissue from the cribriform fossa, from the nose. Okay, fine. So ventilation, your positive pressure ventilation device. Now, it is so interesting. By the time we do our sessions, we have at least 10 sessions for ventilation with our neonatally. Now, those who will be in some lucky sessions, if you ventilate the baby well, the baby will start crying. I mean, can you imagine? I think you should clap for JNCI at this point. They will come after me. You will see the wonders they brought. Thank you. So you need the face mask of the ambu bag that is appropriate for that child. So if you use a face mask for a term baby, for a preterm baby, you'll be ambu bagging the eyes. And you will see ophthalmologist too early. We don't want that one. So oxygen delivery system, intubation sets, and the medications you need. So this is what I talked about, right, in our previous gist. Are we together? Can I leave this slide now? Okay, fine. So please, can you see this flow chart? Is it visible? Oh, good. So antenatal counseling, which Dr. Taiwo and his team has done, but which I will not leave it for them, which I will also see the parents, right? Then the baby is born. We said you will ask, is the baby term, right? If it's term or preterm. So these questions we have here, we need a yes or no. But a single no takes you down the algorithm, right? So if the baby is term, yes, good. If the baby is term and tone is good and baby is breathing or crying, for neonatal resuscitation, we take crying and breathing to be synonymous, right? Good. So, but if the baby is not term, even if the tone is good, I don't understand how the tone of a 28-weeker will be like the tone of a, maybe that one has Rhesus sardonicus and the stiffness of tetanus, right? So if the baby is preterm, that baby should proceed. You should keep the baby warm, maintain the temperature, position the airway. We shall see the landmarks of positioning airway. Dry and stimulate. Can somebody tell me what it means by stimulate? I am particularly interested in this stimulation, right? We just finished Nurses Week. Nurses are great. Good, good, good. So I want a nurse to tell us about, I said, you warm the baby, you maintain normal temperature, you position airway, you clear the secretions if needed. It is not every baby you must clear. If the baby is crying, the airway, there is no secretion, please don't gag the baby. Don't gag the baby, right? But I'm interested in this stimulate. Who can tell us what you do when you want to stimulate? Option A, turn the baby upside down and slap the bum hard. True or false? If you are not guilty of this crime, can I see your hand up? You see? All right, thank you. So it is the fact that you are cleaning the body. That is enough stimulation. Please.
You don't
Please.
say the answer.
Hello?
You have answered.
All right, fine. So when you do that, you want to check, is this baby apneic or gasping? Simple. You are not observing chest rise with respiration, or it is occurring so far apart. That is what we mean by apnea. And if the heart rate is below 100, this is why I said you cannot do neonatal resuscitation alone. You need an assistant. Because you are ready to act. The assistant is holding the umbilical stump and counting with the watch, and is going to count just for 6 seconds. So let me do a little mathematics here. So I count the heart rate, and I get 5 within 6 seconds. What is the heart rate of that child? Oh, good. That's good. So if you count within 6 seconds, multiply by what? Multiply, because so that's multiplied by 10. So if I count the heart rate, which is the pulsation of the umbilical stump, is it below 100? If it is, we'll have to commence positive pressure ventilation. Do we get? Okay, fine. The next step is you've commenced positive pressure ventilation, but the heart rate, is it below 100? You've started and you rechecked. Is it still below 100? If no, it has gone above 100, the child is crying, well, it's post-resuscitation care. You take care of the baby like baby came out well. But if it is below 100, this is going to test whether you came for 2026, right? If it's below 100, you check for chest movement, check ventilation corrective steps, which is about the next slide, and then you may need to commence on an advanced airway. Even after you do that, the heart rate now goes below 60. It should go above 100, right? But if it goes below 60, then you intubate if you've not done that. Because when you intubate, you're going to remove the face mask and connect the end of the ambu bag to the tip of the ET tube, and then you ventilate. By the way, we have a station that will be manned by one of our very skilled personnel, and we hope that everybody is able to intubate when you leave this place. Now, if you do that successfully and it goes above 60, above 100, then you go to post-resuscitation care. But if it goes down, then you give IV epinephrine. So far, so good. Are we together? All right, thank you. So airway, so this is a repetition of what we've said, right? Anything, do I need to make any emphasis here? All right, thanks. So that's airway. So this is airway positioning. Please, I see this will take us, see, pediatrics is soft. See, we are soft in pediatrics. By the time you are entering here, you are sending this child to orthopedics, right? We are not orthopedic surgeons, right? This is, what's wrong with this? Is what? Hyperextended. Now, this is almost closing. Can somebody sing our Nigerian national anthem, but let your chin touch your chest? Will you be able to do that? So some people gag our babies when they are ambu-bagging and do that. No. Now, this is the correct position, right? And those are the landmarks that you would have to help you. Okay, so breathing, we say chest compression. Chest compression starts only when, so indications are that you have The child is apneic and bradycardic below 100, right? You have ventilated. However, after ventilation, the heart rate does not improve and it goes below 60. Don't be confused with this slide. It goes below 60. Now, this is it. This is a positioning. We prefer this in pediatrics. We prefer this. Right? We prefer this one where you use your 2 fingers and compress the sternum. Because we don't know, we have different sizes of hands. Some people's hands are bigger than others, right? So you may not get effective. Now, but there's this rhyme that we should know whenever we make presentations on resuscitation. What is the rhythm for chest compression when the heart rate is above 60? That is, breathe 2, 3, breathe 2, 3. So you are compressing. If this is breathe, so breathe 2, 3, breathe 2, 3, breathe. That is the rhythm. By the time the heart, that is good. This is breathing, right? Good. So we'll do chest. Chest compression becomes that you compress the chest and then you breathe. This slide is for breathing. So that's why we have it here. Breathe 2, 3, breathe 2, 3. Somebody's touching my slides. Okay, fine. So next slide, please, since you are controlling it. Okay. All right. For correct ambubag, the positioning of the face mask, this is it. This is a correct positioning where your first 2 fingers, yes, your thumb and your, which finger is this? The index finger. I didn't go to night school. If I went, I wouldn't be here, right? So you form a C around the face mask, and it forms a firm seal around the mouth and where? The nose of the baby. True or false? Do you cover the eyes also? If it has to cover the eye, then it's too big. If it cannot cover the nose, then it's too small. So you position. Please note the fact that you have one finger that is supporting the jaw, right? That will help you position the baby well. If you miss that finger, very likely the neck will flex forward. And even if you ventilate, you will not get any improvement. Okay, so circulation. We said, we've explained this, right? We say you commence circulation when the heart rate is what? When the heart rate is what? Less than, when it's less than 60. How deep do you compress? Please we don't want to move from neonatal ward to orthopedic theater. If you compress, if the front of the chest touch the back, what will happen? Fracture, right? Good. So we just do just 1/3 of the anterior posterior diameter. In that case, you are compressing. The person compresses 1, 2, 3, then 1 ventilation, right? Why do we have this? The heart rate is much higher than the respiratory rate. True or false? That's why we give 3. The ratio of 3 is to 1. So we say 1 and 2 and 3 and breathe. Any confusion about this? Any confusion between breathe 2, 3, breathe 2, 3, and 1 and 2 and 3 and breathe? In case if there is, let me repeat myself. Heart rate is less than 100, or the baby is gasping, what you do is what? Breathe 2, 3, breathe 2, 3. But if heart rate is less than 60, what do you do? 1 and 2 and 3 and what? Okay, so the facilitators will emphasize this at the various practice stations. So effective ventilation. What if ventilation does not yield appropriate chest rise and heart rate is not increasing? You use this step. You just want to recheck all you've done, whether you are right or you are wrong. The mask size, mask adjustment, the airway positioning, you suction if needed, open the mouth, increase the pressure of the ventilation. And at this point, you start considering alternative airways, right? Endotracheal intubation. We want everybody to be able to intubate by the time you leave this place, right? So drugs, this is one zone that most people leave out. And this is why it's important. Very simple. You started doing chest compression because the heart rate is less than 60, right? If that heart rate persists below 60 for more than a minute, you have to. So we say 45 to 60 seconds. That's why I say 1 minute after you do chest compression, you do not get respiratory rate to rise. Please, you give adrenaline, right? So the question is, how are you going to give it? Do you have an endotracheal tube in situ, or do you have an IV access? Remember I said team. So the person who is doing the ambubagging is not the person who is doing chest compression. It's not the person who is counting heart rate. It's not the person who is setting the UVC. Do we understand? So this is why it is serious business. So if we have an IV access in situ already, very simple, you dilute, because it comes as 1 in 1,000, the adrenaline. So very simple. Just get 1 ml into a 10 ml syringe and make it up with normal saline to 10 ml, right? That's it. So if the weight of the child is 3 kg, right, you are doing 0.3 ml per kg. 0.3 ml per kg will be what? 0.9 ml, right? Good. So that's what you give. Now, so this is just repeating all I have said. These are endotracheal tube, the sizes and the laryngoscope. Now, if for any reason you use a larger size laryngoscope for a small baby, you will cause cleft palate. You will cause traumatic cleft palate. So we have various sizes of endotracheal laryngoscope blades based on the weight of the baby. Are we together? Okay, fine. So if the baby is weighing 3 kg, right? Good. So if let's start with ET tube sizes. Usually babies who are less than 1 kg, you do between size 2 or size 2.5. That is the endotracheal tube. In simple terms, for laryngoscope blades, we have size 00, we have size O, and we have size 1. Just put your mind size 1 for 10 babies, size 00 for extreme preterms. Anything in between is size O. That's simple, right? So if I have those extreme preterms less than 1 kg, I know I'm using size 00. Then you have 10 babies, you're using size 1. Any one in between, use size O. All right, so you have resuscitated this baby, and the baby is doing so well. The baby has started crying. The heart rate is at least 100 and above. What do? You just make sure that you optimize ventilation, make sure you observe that chest is rising, you support circulation, let IV fluid start to preserve flow, perfusion to organs. Make sure that random blood sugar level is normal. I want to ask a question. Again, to our great nurses. Nurses are great. Nurses are caring. All right. Where is the place of olive oil here? Hello, fellow nurses. Where is the place of olive oil here? Maybe the next slide, right? Okay. Whenever I get to theater, I say I'm not a dermatologist. I am a pediatrician. Please don't bring olive oil near me. The problem is, if you do not take care of random blood sugar, you will keep doing everything you are doing. That child has a random blood sugar of 1.6. The child starts convulsing. You know what you do next? You'll be tempted to give diazepam. And that is wrong. Always check the random blood sugar. Maintain normothermia. It's strongly recommended that post-resuscitation care is ensure that you have SpO2 should be more than 90%. Less than that is a problem. So let's look at peculiarities of neonatal resuscitation in preterm babies. Look very well. What we've said so far is neonatal resuscitation regardless of age. But because there is a growing, we're having a lot of IVF babies now, right? And by your experience, you see quite a lot of them coming preterm, right? And maybe many times there are multiple gestation, and so the risk of preterm delivery is higher. So the peculiarities, their heat loss is actually faster than that of the term baby. So you wrap in a plastic. As soon as baby comes out, you receive and wrap the baby. Keep warm, thermal care. Not olive oil yet. Now, they have surfactant deficiency. The first surfactant should be given at the point of delivery. And that is why we want everybody to know how to intubate, so that you are entering theater to receive a preterm baby, not to wait for the person who knows how to give it to come the next day to give surfactant, right? Now, oxygen sensitivity. This is a paradox in preterm babies, right? It's a paradox. They need it, but it's a problem. So it's better we give blended oxygen, right, with a low fraction of inspired. So this air we are breathing, I don't know the percentage oxygen in this room, but if we stand outside, is how many percent? 21%. I do not know what is here now. Good. So, but if we give oxygen directly from the cylinder, we do not want to start with 100. So FiO2, fraction of inspired oxygen, should actually be as low as possible because of complications to the eye, to the lungs, and all that. So you titrate carefully. They have a higher tendency for apnea, meaning that respiratory support is necessary for a little longer in them. You need to watch much closely. They have fragile brain vessels. We are supposed to be able to monitor intra-arterial blood pressure, that is one, through umbilical artery catheterization. But beyond that, we want to limit movement, because if you move the babies too much, there's a risk of intraventricular hemorrhage, bleeding into the brain. Cardiovascular immaturity, careful fluid management. So you give fluid. So for a term baby, you say you give between 60 to 70 mils per kg on day one, and you increase at the ratio of 10 mils per kg subsequently. For preterms, because they have a larger surface area, you start with 70 to 80. Please don't go above that for day one, right? Now, infection susceptibility, strict asepsis is important, and you know that they have their immunity even from skin is less, so we by default give prophylactic antibiotics, get the full blood count, get baseline lab investigations. Now, the challenge you will face, not me, the challenge you will face is when you want to intubate the airway of a 0.5 kg baby, right? That is where you realize that the laryngoscope blade, which should be size 00, may really be very small for that mouth. So at that point, the boys are separated from the men, right? But size 00 will still enter, right? And you'll be able to get it. Summarily, neonatal resuscitation is teamwork. Do you accept this? Is it possible that because the presenter has made presentation, Dr. Taiwo calls me and I say, I am self-sufficient, then I enter theater alone? Does that make sense? I like what is on your face. That's psychosis, right? That if I feel I can. So teamwork is necessary. The golden minute of life is that minute where that child must breathe. That child must cry, right? The evidence of breathing is that the child. So if the child is breathing fine, the child is crying fine, we prefer they cry, right? Neonatal resuscitation algorithm is easy to understand, but only mastered through practice, which we will do shortly. Now, when chest rise fails with all your resuscitation, please, these are corrective steps to Mr. Sopa that you will check. Sometimes it's okay if all you did today is breathe. So take a deep breath. Thank you. I did not exhaust my time, right? So let me re-emphasize that ambu-bagging is different. When you need to ambu-bag plus ventilate, it's different from when you need to only ventilate. Are we together? I have 5 minutes so I can gist that one. So let me say we have 3 scenarios. Four. Scenario number 1, the baby comes out crying because he was born in Nigeria. You know, if that baby was born in Canada, the baby may just say, "Oh, mommy, welcome." You understand? But that baby is crying because he was born in Nigeria. That baby, you just clean the baby, let the baby start sucking. That's scenario number 1. Scenario number 2, the baby's chest is rising. Baby is breathing, right? But you realize that this child is sour-nosed. you do not need to ambu bag. Give oxygen. Is that clear? I realized that that aspect was, this baby is, you can observe chest rise, but there is a problem with oxygenation. For that baby, give oxygen. That's scenario number 2. Scenario number 3, the baby is either apneic or the heart rate is less than 100, but not less than 60. What will you do for that kind of a baby? Bag and mask ventilation at the rhythm of what? 1 and 2 and 3. Can we say it? 1. Perfect. Perfect. You see here, when we go for clinical exams, you understand, we want to know whether we have taught well. So the heart rate is less than 100, but more than 60. You are going to ventilate at the rhythm of what? Good. Breathe 2, 3. Can we say it together? Breathe 2, 3. Breathe 2, 3. Breathe 2. Very good. For those who will be at the stations where the mannequins are from the GMCI company, if you do it, it's going to mark you. It's going to tell you whether the rhythm is too fast or too slow, right? Or you are consistent or you are irregular like one arrhythmia like that. Good. Now, but if the heart rate is less than 60, you will do breathe 2, 3, breathe 2, 3. Very good, very good. So you do what? Louder. Thank you.
Thank you so much, sir. Please, can we give Dr. Peter a round of applause? Are there any questions? Any questions? Okay.
Good afternoon, everyone. Thank you, sir, for the presentation. It was really impactful. But I wanted to ask, you said there is no room for olive oil in theater. So I wanted to know, so how will you now remove the excess venous senosa in the baby's body if you will not have an olive oil?
That is good business. They sell that Vemix and make money from it. Please supply so that I'll do importing and exporting. People buy it. It's for thermoregulation. It's for skin immunity. It shouldn't be removed. I like the queasy look on some faces, right? It's for thermoregulation. It's for early skin immunity. The nurses, our nurses are just looking at me like, what is this person talking about? Nurses are great. Please, accept everything is okay. Right? Everything is okay, and for some sense you want to clean. But really, it's not recommended to be removed immediately. Thank you. Please check it. When you check it and you realize I'm correct, just say, clock it. Clock it, yeah.
Any more questions? Okay, one at the back. Okay, sorry.
Standing on existing protocol, I am a delegate from INEC, and my question is, the presentations have been great, but no one has mentioned the aspect of malformation of the hand, most of the times after birth. Because in my practice, in what I've seen people that grow up, they see their hand is bent. And that can actually, intervention comes most of the times immediately after birth. If that is handled immediately after birth, it can be prevented, and this child can grow up without discrimination of a malformation of one of the limbs. So please, can you just throw more light on that? Because we have seasoned professionals here that would also want to know that knowledge. How do we manage this? to give this child, this person, a good life going forward? Thank you.
Thank you.
Okay, so one of the presenters that would come up after me will be handling congenital malformations, right? But because congenital malformations affect all systems, and we will not be able to finish it today, our world-renowned cardiac surgeon will be talking just on critical congenital heart diseases, right? So when you want to get to the realm of congenital, fine. However, the malformations you said, if we have a critical life-threatening malformation, we have somebody, you have a pediatrician there at birth. Those are the reasons why, that's the reason why we have the obstetrician who screen high-risk pregnancies, where we have anomaly scans, right, that should pick some of those ones. And you have somebody trained for those ones that are life-threatening. But we see a lot of babies born with club foot, right, with some limb deformities. Provided that baby can breathe, that baby is alive. The baby will not go to orthopedics within the first week of life, right? But if it is a malformation that matters to life, then we get the team ready to take care of. I don't know if that helps.
I think one of the physical challenge that babies have, that's hand, the way it was painted, might have to do with shoulder dystocia when we are trying to deliver baby. They can come down with help palsy. That was why the other time I was talking about, if you don't know how to manage shoulder dystocia, you should not have any business doing in the labor room, because it's something that can occur suddenly. And one of the complications of shoulder dystocia is the help palsy. Of course, once it's that happen, obviously we'll still we still manage it, but we want to prevent it, and that is why we, the obstetricians and the midwife, need to continuously be trained on how to handle that situation. You should have it at the back of your mind. The head of the baby has come out, and the head is receding back. You should suspect shoulder dystocia. And why he was talking about teamwork, in labor room, you should not be the only person, because this thing can occur. And if you don't deliver, 60 seconds is also one of the golden rule in that one. You want to deliver, or else, beta asphyxia occurring, you are likely going to be pushing, and even when you now have people around too, we are not doing thunder pressure. You know, the way some other people do it, it makes the matter worse. So these are important things that need to be considered. It starts from us, the midwives, the obstetricians, doctors, traditional birth attendants that are taking delivery to ensure, especially, we prevent Erb's palsy when a baby is not able to get delivered. And we need to continue to get trained to prevent that. Then the congenital anomaly, as earlier said, we can always pick from anomaly scan. There are indications for doing anomaly scan. Anomaly scan is not just for everybody, but in the course of history, if we are having advanced maternal age, is a risk factor for coming down with congenitally abnormal baby. If a woman has been exposed to some medications earlier on during the embryonic, during the first 8 to 10 weeks of life, you are likely going to have, if they are teratogenic drugs, they are likely going to come down with congenital anomaly of various grade. It can affect the brain, it can affect the heart, it can affect the musculoskeletal system or the intestine. It can affect. So that's why anomaly scan. So when we take history, we quickly identify and mark those people that between 18 and 20 weeks, they should go for anomaly scan. Once we recognize, then it is the best time to quickly refer to tertiary center where such can be managed. We should not keep until we now deliver and we are looking for where to take care of the baby.
Thank you. So I saw some other hands up. So we have somebody's there. Okay, you can.
All right. Thank you, sir, for your presentation. My question is, what about if the resuscitation fails? Maybe despite adequate ventilation and the chest compression, the heart rate remains 60, maybe even after the drugs, the heart rate remains below 60 beats per minute. So what's the fault, and for how long can we continue the resuscitations if the patient is not responding? Lastly, like this, is there any time limits that we can just maybe give up or add something like that?
Okay, thank you. So the question is, how long will I ventilate this child for 30 minutes and say I'm okay? Will I do for 1 hour and say I'm okay? Now, I will approach it from the neonatal resuscitation algorithm. I will approach it from medical legal perspective. Then you will work out the answer for yourself. So what is neonatal resuscitation? The steps are A, B, C, D, E, right? I guess many people ask that question, how long do I ambubag? Is that the question? That is the question, but you are stopping at step C, which is like you ambubag, you do your chest compression, you've stopped, you've just done A, B, and C. You go to D, right? By the way, the adrenaline infusion, you can do it rapidly even after every 3 to 5 minutes. You continue. With the step E, where the baby is intubated, you connect the baby to a ventilator. If the baby dies on the ventilator, you have done your best. Have I answered the question? But I know the challenge. Not every center has a ventilator. That is why I said I will answer the question from the neonatal resuscitation guideline, but now talk about it from the medical legal perspective. So you are in a big fix if there is no ventilator, right? What's the ventilator going to do is going to take over the respiration. I'm sorry, continue giving the respiration. Continue giving the respiration. Yeah? Continue giving, yeah? Until ventilator arrives. I know you want to hear 10 minutes, 15 minutes, 30 minutes. I know you want to hear that, right? However, I know there is that cutoff, I think it's 20 minutes, right? But I do not want you to leave here and say, I ambubagged this child for 20 minutes, 30 minutes, and the heart rate has not gone above 10, and so I stop. That is what I do not want you to leave here with that impression, because airway, breathing, circulation is not the end of neonatal resuscitation. You talk of the end after you've gone to the drugs, gone to intubation, connected to ventilator. Now, to answer the question from the other side, you do not have a ventilator. Please continue ambubagging. You will be safer. You will be safer in the court of law that you ambubag this child for 2 hours and after the child packed, than you stopped after one guideline says 20 minutes. The person who will review the case will say, you stopped. You stopped at C. Why didn't you do D? Why didn't you do E? Is it clear? I have answered your questions with a lot of gaps in your mind. True or false? Okay, thank you.
You have one more question at the back, sir.
Okay.
Okay. Standing on existing protocol, so you made mentioning of not putting rubbing olive oil on a child. What's of the case of RVD patient, a child that is born, the mother is RVD? Is it not better you clean up the child? That's the first question. Then you also made mentioning of checking of sugar. So I feel like checking of sugar maybe should be done maybe after 2 hours, because the mother, actually the glucose to the mother is still there. It will be higher. So maybe doing sugar, it should be 2 hours because everything has normalized. I don't know.
Okay, so I really respect the physiology of 2 hours. However, have you had any experience of hypoglycemia within 5 minutes of delivery of the baby? I have experienced, I've taken. You understand? So there is physiology, there is pathophysiology, right? So somebody should quickly check and correct. Whether the mother is RVD positive, or the mother is hepatitis B positive, or the mother is unknown status, who is that compassionate doctor or nurse who enters resuscitation with bare hands so that we'll give you one bag so that you take something from inside? Eh? We want to get our heroes, those who resuscitate with bare hands, right? So please, you receive the baby. It's controversial. People are so used to cleaning off and applying olive oil. When Vemix business is in millions, do you get? Please go and browse it. You make money. Eh? So please, we do not rush to clean off Vemix. You get a baby, you dap. Eh? Just let the baby be dry. That is what we want. You can talk about cleaning with olive oil. By the time you are done with everything resuscitation, you are 100% sure baby is stable, right? But I know abroad, they want to leave Vemix for up to 2 to 3 days, right? They want to leave it that long. But because we are transiting, you can only do that after the baby is very stable. JNCI presentation is next. We said we have one last question, right?
Okay.
Okay, thank you so much, sir, for that wonderful presentation. My question is on the rhythm. For a baby having pulse rate less than 100, we have to do the breathe, 2-3 breathe. I want to really get that 2-3. How many is the rate of the compression we give? The same way you talked about, if the pulse is less than 60, we give 1 and 2 and 3 and breathe. The other one did not carry, and is there any difference? Like, let me get it, please.
Okay, thank you. So the question is very practical, but I want to do reverse. I want to answer that question from a reverse angle. Who can answer that question for us from this seat? I did simple random sampling. Did you hear the question? Oh, anybody who is on TikTok here is wrong when stuff is moving. So the question is, so I will repeat the question, and then the person who is going to answer it, you bring the bag for the person to put the hands inside. The question is about the rhythm of resuscitation. We say 1 and 2 and 3 and breathe, right? The other one is breathe 2, 3, breathe 2, 3, right? About the rhythm, right? Sorry. So I think I should answer it so that I'll pick my own. Okay, please come. Let's hear your question very clearly so that they will hear. You understand?
No, sure. Okay.
Let somebody know. Someone. Okay, yeah.
Okay, based on what I understand from your question, she's asking if with heart rate of less than 60, we are doing 1 and 2 and 3 and breathe. How are we compressing for breathe to 3? I believe that is your question. So for breathe to 3, it means that the heart rate is above 60 and you don't need chest compression. You only need ventilatory support. So you give 1 breath, 2, 3, breathe, 2, 3. So that just gives you the reading. So you can get 30 breaths in 1 minute. Do you understand?
Yeah, at least 30 breaths. It should be 60 for maximum. 30 to 60, right?
Yes.
Good. So, but for the compression.
Okay. So the breathe to 3 is the reading for just ventilation. No chest compression. You are not compressing because the heart rate at that instance is greater than 60 beats per minute. So the reading is breathe 2, 3. And you need that reading so as to be able to deliver about 30 to 60 breaths in 1 minute.
Okay, look at, so this is ambu bag. Assuming it's ambu bag. So see the compression of my hands. So breathe 2, 3, breathe 2, 3, breathe 2, 3, breathe 2. So yeah. Oh, perfect. I have supporters here. So this is the ambu bag, right? Should I put it on my mouth? I'm a baby. So it's breathe 2, 3, breathe 2, 3, breathe 2, 3. That's what it means. breathe 2, 3, breathe 2, 3. That is the rhythm, right? But if it is 1 and 2 and 3 and breathe, meaning the heart rate is less than 60, right? Somebody is doing 1 and 2 and 3 and breathe. 1 and 2 and 3 and breathe. 1 and 2. Is that clear now? Okay, thank you. Okay, I think we're